going to look at airway management. It's going to the oxygen bottle. We'll put on the regulator. To make sure that the regulator is okay, there's a bow tie seal here, and what we line up the seal and quarter turn to secure it. It's nice and tight. Turn on the oxygen. There is a good level of oxygen there, which is great. To make sure that there is no leaks in the bag, we test the bag. There is airways in the bag, which means there is no holes in the bag. Just connect the tubing to make sure that there is no leaks in it. We turn it on and we should be able to feel the air from here, from the end, which we can, which is great. Connect it up. We should, we'd be looking at an oxygen level of a 98%, which is 10 to 15 litres. We'll also be looking at the chest rise of between 4 and 6 ventilation at 98% oxygen. We'll look at the chest rise and for gastral rise. Today we're recording the suction. Before we test on our patient, we actually need to make sure it is all working fine, that it's got the water bottle on the side here. It would usually have a bag inside the suction cup here, and that there is no blockages in the catheter. To do that, we turn it on, press test, hold suction. We wanted it to go above 350 milligram mercury, which it is. Make sure by closing the circuit that the suction. We only suck on the way out for no more than 10 seconds. Put it in as far as we can see and suck on the way out. Complication is if we put it too far back, can actually cause hypoxia if we do it for too long, or cause problems with breathing. Also, we have to use a soft catheter in a moving vehicle, and only the hard catheters for staying still in non-moving vehicles. Today we're looking at an OPA. OPAs are used when the GS is lower than 8 or verbal response lower than 2. For the OPAs, we check from measuring from the corner of the mouth to the ear. We tilt their head back, check to make sure there's no obstructions. When we set it in, we twist it when it's halfway there and slide it down. Complications from an OPA, if it's too large, it can induce vomiting, and also if it causes an obstruction if the OPA is too small. OPAs are similar to an NPA. We measure them from the nose to the ear. We have to make sure that we do not use them if we suspect a basal fracture. Make sure we lubricate it. Tilt the head back, check for any obstructions, and insert it in. If it doesn't go in the nose, you can wiggle it a wee bit, see if it goes through. Or if that doesn't work, try the other nasal. Complication with it, it can cause further bleeding, which is a problem. For fracture management, we take into consideration the split disc allergy, which is P for pain, P for pain, L for loss of function, U for unusual movement, S for swelling, D for deformity, I for irregular, S for shortening, C for crepitus, S for shock. And that will influence whether or not, with those signs, if there is actually a fracture. Now, with the patient, we'll need to make sure we get permission to check a wound, and also we'll need to find out what his pain level is. He has stated that he's on an 8, which would mean Antinox is a good choice of pain reliever. For Antinox, we'd actually have to make sure it is the right bottle and that it's not oxygen. With medication, you also get your partner to check it. We would find out from the patient if he had any allergies, if he's been scuba diving in the last 24 hours, if he has any abdominal obstructions. We would also explain to him ask him that he would like the Antinox and get his permission. Tell him that it takes 5 to 6 breaths for it to work. It can cause metallic taste. It's also sometimes you will feel sleepy with it. That it's the fact it's quite good, the fact that with it just being oxygen and nitrogen. We would also, if he gives his consent for the Antinox and there's no complications and no allergies, we would let him self-medicate. There you go, sir. You can have that. We would check both sides of the legs, check for the pulse, and we can feel the pulse, check the temperature in both feet, do a cap refill, which are both fine. We would explain to our patient that soon we're going to put on the splint, which I've already cut out earlier. To make the splint a wee bit more comfier, we have the towel. Before we lift the broken leg, we had explained to him that we're about to soon lift it and it will possibly be sore. Then when we lift it, we slide the box slide in. tie the fracture up from below the fracture to the side. Above. Fracture and from the shape of the knight. We would also, once it's tightly secure on, recheck for a pulse, and it's fine. Recheck cap refill and the temperature of both legs. Today we're going to look at colour applications, colours we put on if we suspect they have a spinal fracture. For it, we need to make sure that everything is away from the neck, that we have somebody to hold the head in an anatomical alignment. To get on the collar, we measure from the length of the neck and place it over here. We readjust it as needed. Place it under him, keeping him anatomically aligned, putting it on as tight as possible. Assessing dangers, there's no dangers. Approaching the patient, check the doctor's ABC. Sir, can you hear me? No response. Checking for breathing for 10 seconds. No breathing, can you start CPR please?
Push and connect electrodes. Push, analyze. Connect, push and analyzing now. Stand clear.
This is AUT
No
1.
shock. Advise.
We have an R49.
Start CPR.
We require an R50 please. Now, has anybody seen what happened?
3, 2, 1.
Just
Ventilate.
carry on, please.
Ventilate. Three, two, one. Ventilate.
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 Carry on. So has anybody seen what happened? No, nobody knows
3,
what's
2,
happened.
1. Ventilate. Ventilate.
Shake me.
3, 2, 1. Ventilate. Ventilate.
14 seconds we'll be changing over.
Okay.
You can do the ventilate while I do CPR. 6, 5, 4, 3, 2, 1. Change over.
Push analyze.
And analyze, everybody stay back.
Analyzing now. Stand clear.
Do not touch.
No shock advised. Start CPR. Three, two, one. Ventilate. Ventilate.
Today we're going to look at doing the vitals, do the radial pulse, and also check the respiratory rate. Tabitha, do you mind if I place my hand on yours to check the radial pulse?
Yeah, that's
And
fine.
for 15 seconds?
Yeah.
And I'll also check the breathing. That was really good. It was a good, strong, regular beat. It was 20 beats. So times that by 4, which is 80, which is perfectly within the normal range. The normal range is between 60 and 100, so that is all perfectly fine. Just hold it on for a second again, just to check the respiratory rate. We measured it for 15 seconds. We got 4 breaths within that 15 seconds, which is 16, which that's really good because the normal range is between 12 and 20 for respiratory rate. For our vitals, we'll just check the respiratory, checking the lobes to check if they're all okay. Tabitha, do you mind if I check the lungs to see how they are?
Yeah, sure. Can you get enough space there?
Yep. Can you take a deep breath in, please? Another deep breath. Another deep breath. And another deep breath. That was really good. There was no crackling, all was fine. There was no sound, which means that there's no sign of wheeze or stridor. There's no chest infection, so all's good. This is all normal. Hi Emma, I'm Trisha. Today as part of your vitals, I'm just going to be checking your blood pressure. Are you happy enough for me to check your blood pressure?
Sure.
Okay, what I'm going to do is I'm going to put this on your arm and as the cuff blows up, you'll feel it in your arm. It might be a little bit sore, but hopefully it should be okay. And then I'll just release the pressure to be able to check the blood pressure. Are you still happy enough for me to do that?
Yeah, sure.
Okay. Just going to put your sleeve up so that way it takes the fluid out of it. I'm going to line up the arrow here with the brachii artery. Just wrap it up. Sorry. Let's get you to hold that for me, please. As I feel for the brachial vein here, or pulse just here on the inner arm, I'm going to pump this up. Once I no longer can feel it, I'm just going to pump it up one more time, and then I'll hit on my stethoscope and slowly release it. That was good. It was at 110/90, which is well within the range. For the systolic, it's supposed to be up to 140, and within the range of the diastolic is usually around the 90. So within the range between 90 and 140 is fine, and yours was all fine.
Thank you.
For today, we're going to do our ECG monitor check with our LifePak 12. We just check at the back to make sure that the batteries are okay, which that one is, and that one's got 1, so we will need to charge that later. To turn it on, we turn it on. Put it into manual mode. Do our operational checks. Go to menu, user test. Just waiting for it to test. While it's testing, I'll just get out my shock for testing the shock. User test. Still doing the user test. It has passed the test. Battery 1 is low, which I will charge strictly after this video. For doing a shock, we can press charge. Give a shock. Press shock. NHE delivered. If we do a charge and we want to disarm it, we can hit here and it'll disarm the shock. For checking the leads, we can go leads down to 1, 2 and 3. Then we'll actually get a reading, and we'll also get a heartbeat as well as the ECG. If we want to change the size of it, we can go size and then either alter it to whichever size we wish. Stick it on 2.5. Also, if we need a blood pressure cuff, there's one in the back. ECG leads are here, and also our shock leads are here. And that is the ECG Life Pack 12. Hemorrhage control. Today we're going to look at doing hemorrhage control. First, it's important to clean out the wound, so let's get the Stenlon solution and pour it over the wound. Also, we get the gauze and get the smallest piece we can, as this will help the pressure. And as we bandage it up, it's important to twist it on top of it, as this will aid more pressure. Let's get my offsider to hold it. Can you hold the arm, please? Yeah. That way, as the offsider usually would be another paramedic, is doing indirect stopping the bleeding. Just keep holding that. Good boy. If this would continue to bleed, we'd do a second one on it. We can also do, by holding the arm up, actually prevents blood there. The other option, if it's quite severe, is putting on a tourniquet. Tourniquet, we put it on 10 centimeters above the wound. And we put it on as tight as possible. If you hold this arm, you twist the half, cut it around, put it in. And it's really important to write the name and the date and the time you put the tourniquet on. The time is 5 to 2, so we'd write that down. If the bleeding still continued, you can put the second tourniquet on. You put it approximately to the first tourniquet and just above it. Thank you. You have to wait. Ezra, when Mommy asks for the offsider to sit and hold this, then you're going to come, okay? But until that point, can you be quiet, please? Thank you. So I have to make sure we got our gloves and gloves thing on, okay?
I want to help.
Yeah, because he's our way, okay?
I just say you don't want to help.
But we do want to help with the paramedics.
But you want to help.
But it's important to help him. He's our
I
way.
need two help.
Yeah, he needs 2 people to help him.
People.
Okay, so can we do this now again? Thank you.
Did it.
You did it!
Okay, these up.
No, wait. Then there's other stuff you need.
Yeah, recording stop.
Oh, why don't people do more? Okay, can that be more?
You can take the glasses off.
What about you?
No, I keep my glasses.